having invited me, and I felt a little uncomfortable that I had to speak in front of Dr. Angela Vincent, who is an exponent in this field. But however, I'll try to give you a share about our experience, how we go about this topic in a resource crunch situation. Sorry about the delay. How do you go down? How do you go down?
The next is previous.
Okay. So I'd like to share with you a clinical approach to paroxysmal neurological disorders in the Indian context. I bring greetings from Christian Medical Bellow. So basically the scope of the topic is definition, channels, mechanistic perspectives, channelopathy, synaptopathy and circuitopathy, sites of neuraxis affected, the neuron, the peripheral nerve, the myoneural junction, the muscle, skeletal muscle, cardiac muscle, and a disease-based approach, how do we approach, and the need for algorithm in the setup. So basically these are, you have discrete episodic impairment with heterogeneity in terms of phenotype, genetics, and pathophysiology. And there is dysfunction, could be at the channel level, or it could be a synaptopathy like ligand channels, or it could be even a circuitopathy where you have patients like stiff person syndrome where interneurons get affected. So etiology could be either genetic or acquired in the form of autoimmune disease. And the diagnostic problems we face in our setup is when you have facilities for genetics and antibody settings is lacking. You need clinical-based algorithms and electrophysiological tests, or even develop in-house tests in your lab, basically biochemical tests for diseases like Mingy, where you don't have thymidine phosphorylase gene, and get the biochemist to make thymidine phosphorylase activity in the peripheral leukocytes. So, is that a pointer here?
Yes, sir.
So here, this is a cartoon, which actually, this is a review article which came in 2013, which shows the normal synaptic cell membrane with the vesicles, with the channels coming down, and you have basically antibodies can affect the channels, or even the regulatory proteins which affect the channels. So you can have antibodies at different level which can cause dysfunction. Similarly, genetic disorders mutations can also cause dysfunction at various levels. Similarly, you can have synapse, just like you have in the myasthenic syndromes, you can have dysfunction when there's a normal synapse, a presynaptic problem, at the synaptic problem, postsynaptic problem, and so this is an example. Or you can even have like stiff person syndrome, where you can have a problem with a defective interneurons. So problems could be at anywhere from an ion channel to a ligand channel to a circuitopathy. So basically, where could be the sites of dysfunction? Neuron, skeletal muscle, cardiac muscle, neuromuscular junction, and peripheral nerve. So this is a landscape of disorders. It's the common complex disorders are migraine, epilepsy, TIA, and syncope, and the rest of the disorders. And you can hear myasthenia gravis and Lambert-Eaton syndromes. This is basically the landscape. There are a whole lot of problems. So basically, they involve the CNS, PNS, or sometimes you have CNS and PNS. Mostly, they usually affect only one system, but sometimes you have patients which could have more than one system getting affected. And there are common and complex disorders. The common disorders are migraine, seizures, TIAs, and syncope, which already the topics have been handled. So basically, talking about acute presentation of two NMDA positive patients, new 23-year-old female with a new onset focal motor seizures evolving to status epilepticus, autoimmune, autonomic changes, behavioral changes, PET negative, NMDA positive with suboptimal response to plasma exchange, response to rituximab. The second patient is a 28-year-old female with a neuropsychiatric syndrome, hypersensitivity to antipsychotics, Akinetic rigid syndrome, catatonic spells, cognitive involvement, NMDA positive, treated with IVIG, steroids, cytotoxic medicines with symptomatic but a chronic presentation. So the most common symptoms we see in our group are actually cognitive impairment and behavioral changes, fluctuating symptoms, transient aphasia, tremor, myoclonus, ataxia or gait disorders, seizures, generalized or partial sleep disturbance in the form of hypersomnolence or insomnia, headache, lateralized motor or sensory deficit, and psychosis and paranoia. And these are the symptoms. We have about 23 patients, anxiety, autonomic disturbance, cognitive decline, myoclonus, and headache. These are the misdiagnoses which patients have. There are patients who are referred as viral encephalitis, meningoencephalitis, CJD. We had 2 patients with CJD presentation, epileptic encephalopathy, Alzheimer's disease, Lewy body dementia, psychosis, metabolic encephalopathy, and delirium. And you can see the breakup of the syndromes: meningoencephalitis 6, CJD, encephalopathy 7, encephalitis 4, epileptic encephalopathy 2, and rapid cognitive decline. And you can see the breakup of meningoencephalitis and epileptic encephalopathy. 1/3 having fluctuating symptoms, 1/3 having progressive symptoms, and 1/3 having fluctuation and progression. And as you see, we have a problem of antibodies. The problem is you have to have good labs like Professor Vincent's lab, like Oxford and all. We have to rely on labs which are not too reliable. So we don't have facilities of voltage-gated potassium channels. And these are the MRI findings. You can have a good number having normal MRIs, CJD-like, limbic encephalitis, diffuse abnormalities, EEG. About 14 of them were on steroids, long-term immunomodulation 8, IVIG 11. So basically 50% of the NMD encephalitis we found with normal MRI, majority abnormality limbic encephalitis, cerebralitis, and striatal encephalitis. CJD kind picture. This is a response to treatment, and a good number relapse. And outcome, this is the breakup. And a good number of them have autonomic symptoms. And if you look at the series, you have 22 patients who have median age was about 40, range about 6 to 70. Most frequent clinical features were 77% having cognitive decline, autonomic dysfunction in 59%, sleep abnormalities in 59%, myoclonus in 45%, extrapyramidal signs in 41%, seizures 41%, headache 32%, and anxiety 32%. About 68% of these had fluctuating signs and symptoms, and the presentation at onset was like encephalopathy in 32%, CJD presentation in 27%, encephalitis 18%, meningoencephalitis 9%, epileptic encephalopathy 9%, and MRI abnormalities were found in about 68%, and EEG abnormality in 45%. Autoimmune markers were present in 5, elevated thyroid antibodies in 5, NMDA receptor antibody in 2. In 41% CSF fluid abnormality suggests an inflammatory process, and the presence of dysautonomia was associated with poor outcome, and steroids were given in 64% associated with a good outcome. So basically the clinical laboratory and radiological findings of the SRE was variable. Misdiagnosis presentation is common. Diagnosis should be considered even when thyroid antibodies and neuronal surface antibodies are negative. And it's a clinical diagnosis, and diagnosis of exclusion, thus CSF fluid profile and neuroimaging results could be non-contributive. And more than one etiological mechanism could lead to an autoimmune and inflammatory encephalopathy. And you need further insights into the pathophysiology with larger sample size. Now this is basically a gross thing about paraneoplastic syndromes, classical paraneoplastic and non-classical, tumor present, tumor absent, onconeural antibodies present, onconeural antibodies absent. And these are definite possible, these are various criteria. And this is again a busy cartoon. So that you can just look at shows the spectrum of the paraneoplastic syndrome we had about patients with about limbic encephalitis, we had about 4 patients, stiff person syndrome 3. So this is a case scenario of a patient who came 2 weeks ago, a patient who came with recurrent episodes of headache for 8 months and progressive asymmetric spastic weakness of lower limbs. Evaluated for the same and was started on ATT with progressive worsening, and PET scan had showed lymphadenopathy and biopsy showed non-caseating granuloma, and the pathologists outside had asked tuberculosis could not be ruled out, and the patient was on ATT. And this is basically what the scan showed: hypertrophic pachymeningitis, nodular meningeal enhancement. And when the patient came 2 weeks back to us, she was actually breathless and she had a complete heart block. And she actually had high ACE levels, and this was sarcoid. So you can always have some episodic phenomenon which can happen. We couldn't do an MRI, unfortunately, in this patient because the patient was on a pacemaker. So this is one entity where. The next one is actually a 44-year-old gentleman, short duration illness with ptosis, bulbar dysfunction, proximal weakness of both lower limbs, with gait disturbance, with dynamic stiffness and imbalance of gait, and probable appendicular ataxia with stiffness of trunk, fatigue, no raised ICT, dysautonomia, with a background history of weight loss, cough with expectoration. The neuraxis without postsynaptic or presynaptic, cerebellum, spinal cord, and dysautonomia. So the possibilities considered was a Eaton-Lambert syndrome, a stiff person syndrome, and a cerebral channelopathy. How do you play this? Yeah. No, the earlier one.
Where's mute?
Huh? This one. Why is not playing?
This.
Sorry, the earlier one is actually showing us actually significant spasms in the paraspinal muscle, which is showing a stiff person.
जल्दी जल्दी कर और बिल्कुल नाक पे लगाना, टिप पे.
Steadiness. So basically, the patient, I try once again to open that video, if you do. So basically, patient had a postsynaptic and postsynaptic was a presynaptic neuromuscular transmission defect, autonomic involvement, a stiff person syndrome. From the video it was there, and a paraneoplastic cerebral degeneration and channelopathy. The conduction showed reduced CMAPs from the median. From the median ulna, and RNS at 2 Hz had actually showed positive decremental response. Single fiber EMG showed an abnormal jitter, and you can see the 2 Hz stimulation showing decremental response and the 30 Hz stimulation showing an incremental response, significant incremental response. This is one of the slides I had borrowed from Montreal, which is showing significant incremental response. Again, if you don't have RNS facilities, you can do a post-exercise incremental response. And this is actually a continuous muscle fiber activity in a EMG. And after diazepam, it has actually come down. So basically, low CMAPs in right median and both ulnar and peroneal, RNS showing decrement, And after contraction, there's significant increment is there, incremental on 30 Hz stimulation. CMFA was seen for the paraspinal muscles. Single fiber showed abnormal jitter, and there was no abnormalities, no features of denervation. And the CT thorax had shown actually a lesion in the thorax, and MRI showing cerebral atrophy. CT guided biopsy showed features of a lymphoma, and anti-amphiphysin antibodies were not done because we couldn't do it. The pathology report showed a lymphoid cell with increased pleomorphic nuclei. So basically, patient had a lymphoma, and we started on treatment and basically was given chemotherapy and was given pyridostigmine for ocular and bulbar symptoms. There's improvement in the ocular and bulbar symptoms, worsening of stiffness and rigidity, for which the patient was admitted and we had given him plasma exchange. Diazepam was given stiff person with follow-up. The patient he survived for about 4 years and then passed on. So basically, you have a patient with non-Hodgkin's lymphoma with a paraneoplastic syndrome of LEMS, coexistent myasthenia gravis, cerebellar degeneration, and a stiff person syndrome. I'm sorry I couldn't show you the video. So stiff person syndrome, the variants are stiff limb or PERM. You can have a GAD associated or an amphiphysin associated. And GAD associated, usually the topography is actually codocephalic. Amphiphysin associated is usually involving the arm and neck. So next is actually a patient who presented to us with a fatigable ptosis, diagnosed myasthenia. This he came to us about a month ago. CT thorax showing a thymoma, showed a CT guided biopsy showed a thymoma because he had an infiltrative tumor for which surgeons were not willing to were needed to give pre-op or radiotherapy, and patient developed myasthenic crisis and was given IVIG and slowly weaned off the ventilator. Develops intermittent episodes of restlessness with confusion, with dysautonomy and seizures. No confounding features like sepsis or metabolic derangements or hypocarbia. You can see the video showing tonic deviation of the eyes. And the patient and he's not responsive. So this is the MRI shows features of involvement of the right occipital cortex, the thalamus, and in the insular cortex region again. So this is again a syndrome where you have a myasthenic syndrome with a thymoma with a CNS involvement. This is a cartoon showing the myasthenic neuromuscular junction. We just go for looking at the myasthenic syndromes like early onset, late onset, thymoma with various other antibodies, the MUS phenotype, the seronegative ones, and the ocular. These are the various tests. Presynaptic, again, we spoke about the cordocranial progression, ocular never getting involved, but voltage-gated calcium channel antibodies. Again, this is a stereometric analysis of the synapse showing abnormalities there. Again, this is again a cartoon showing the various levels at which the calcium channel antibodies work on it and affects the release of SEH. So again, RNS showing decremental response at 3 Hz and rapid RNS showing incremental response. This is a table actually from Sarah Finlayson, which is showing features of various features of the congenital myasthenic syndromes. Cholinesterase transferase deficiency affects in birth and infancy with episodic apneas, and ophthalmoplegia is usually absent, and they could have respiratory crisis and they could be normal in between attacks. You can have ACHE deficiency, which can affect in birth or infancy or childhood with ptosis, falls, and slower movements and poor feeding. Ophthalmoplegia is usually present and they usually slowed pupillary response following constriction to light. They can have chronic hyperventilation. Again, the DOX7, where they have normal development in childhood, following which they develop a limb girdle weakness. A slow channel syndrome, which I will show later, where you have significant finger extensor weakness. This is a table showing differences between the autoimmune and congenital myasthenic syndrome. This is a lady showing finger extensor weakness in slow channel syndrome. Next is actually an EMG of a girl who was a nurse with us, who came to us with a myasthenic syndrome and was not responding to periodostic treatment. She had repetitive CMAPs positive, and she actually had a slow channel syndrome with profound finger extensor weakness, and she was actually treated with fluoxetine and did well. So this is again a flow channel. This is again from Serafin Lassen's thing. So basically you have to look at the phenotype, and the phenotype is like a DOX7 and a slow channel. You should avoid pyridostigmine. You should use terbutaline or ephedrine. We usually use terbutaline. If it's a slow channel, we use fluoxetine. So basically in a setting like ours, we really need to have good clinical, you have to look at the phenotype carefully before you start, because we really don't have the know-how to send the genetic markers is not easy. Now this is again a boy who has got a DOX7, probable DOX7, who actually has a limb girdle weakness. And on exercise,
चलते चलते बैठ जाता है कभी कभी चलो वापस चलो ठीक है नीचे बैठो नीचे बैठो बेटा उठो दस बार करो वैसा
So basically this is an algorithm where we look at myasthenics. What we actually do is ocular generalized RNS. If decrement is negative, we do a single fiber looking for abnormal jitter. We also decrement positive, we send for ACHR antibody and CT thorax. If ACHR antibody is positive, response to immunotherapy is good. If it's poor, and if the ACHR antibody is negative, you have to relook at the phenotype and look for MuSK antibody, where you look a phenotype, either middle-aged ladies with neck weakness and bulbar weakness, or whether it's a CMS, congenital myasthenic syndrome phenotype. So you really need to look at the phenotype carefully. Now we come to muscle channelopathies. We look at myotonic disorders, episodic weakness, and malignant hypothermia. So muscle stiffness could be due to sarcolemmal hyperexcitability or flaccid weakness due to sarcolemmal inexcitability. Overlaps could occur between myotonic disorders and periodic paralysis subtypes. So this is basically a chloride channel is a myotonia congenita, myotonia without periodic paralysis. A sodium channel is paramyotonia congenita or potassium associated myotonia, hypokalemic periodic paralysis or hypokalemic. Potassium channel Anderson-Tawil syndrome, and calcium channel is hypokalemic periodic paralysis or malignant hypothermia. So this is basically the myotonia, dystrophic myotonia DM1 and DM2. The pure myotonias, the paramyotonia congenita, potassium aggravated, myotonia fluctuans, myotonia permanens, and the dystonia and the myotonia mimics. Again, DM1 and DM2. DM1 usually has facial and distal weakness, whereas DM2 has proximal weakness. DM1 has CTG repeats and DM2 has CCTG repeats. DM2 has proximal pain and muscle hypertrophy. Maternally transmitted disease in DM1. Myotonia is not universally present in the DM2. Again, this is a table showing differentiation between paramyotonia congenita. Inheritance is autosomal dominant. Age of onset in neonatal and infancy. Distribution is face, tongue, and neck. Cold-induced weakness, swimming in cold weakness, swimming in cold water, tongue stiffness after ice cream. blepharospasm, muscle hypertrophy is absent, whereas in myotonia congenita, they have early childhood, face, arms, and legs. They usually have a warm-up phenomenon. Muscle hypertrophy is present. They respond to myxolytin and phenytoin. Myotonia, the Becker's dystrophy is an early onset, autosomal recessive. The weakness is more, and they respond to myxolytin and phenytoin. People even try steroids in them. Next one is potassium aggravated myotonias. They are called myotonia fluctuans, myotonia prominence, and acetosolamide responsive myotonia. Next is hypokalemic periodic paralysis. You have autosomal dominant, usually manifesting in the second decade, calcium channel, sodium channel, or potassium channel, exacerbated by rest after exercise, cold or carbohydrate loading, spares of respiratory and bulbar and facial muscles. Duration of attacks is for hours to days or moderate to severe tears are absent. About 25% can have chronic myopathic form, and you can prevention by acetosolamide or high potassium diet. Myotonia never occurs, and potassium is invariably low during attack. You can have secondary periodic paralysis, hypokalemic, suspected in those without family history, presentation after the age of 20. Causes could be thyrotoxicosis, RTA, autoimmune due to Sjogren or Wilson's, adrenal adenomas, drug-induced, or steroids, insulin and beta agonists. Hypokalemic, autosomal dominant, first decade, attacks decline after 50, sodium channel or potassium channel, exacerbated by rest after exercise, cold or potassium loading, pregnancy, steroids. Proximal and symmetric flaccid weakness, attacks last minutes to hours, more frequent attacks with mild or moderate attacks and sometimes could be fatal. Hypokalemic periodic paralysis, paresthesias may herald the weakness. Older individuals may develop a chronic progressive weakness with pelvic girdle. Potassium could be normal during the attack. Myotonia and periodic paralysis indicates hypokalemic periodic paralysis, clinical in 20% and electrical myotonia about 50 to 70%. Interictal lid lag and eyelid myotonia, treatment is with inhaled salbutamol. Prevention by acetosolamide or thiazide diuretics. Biopsy might show vacuolar myopathy. This is a 13-year-old patient who presented with 2 episodes of flaccid quadriparesis 1 year apart, and conduction was thought to be motor axonopathy. In the first episode, patient spontaneously improved, and this is a phenotype showing hypertelorism and dental and clinodactyly. ECG actually showed bigeminy and had prolonged QT interval. This is an Anderson-Tebel syndrome. And this is again a mutation of invert rectifier KIR2.1 encoded by potassium channel, episodic weakness in the first or second decade. Hypokalemic normal or hypokalemic attacks are also reported. Cardiac arrhythmias could be due to QT prolongation, prominent U waves, premature ventricular contractions, polymorphic VT. They have small mandible, ocular hypotelorism and lucid tears and clinodactyly. Sometimes they might require ICD or amiodarone because they could have fatal arrhythmias. We talked about myotonias. We go to the EMG. In myotonias, you look for myotonic discharges, and DM1 you develop waxing waning pattern of myotonia, and DM2 you develop waning. You do a long exercise test, McManus test for periodic paralysis, or there is even a short exercise test with Fournier patterns of an analysis which actually can differentiate between the different types. I can now come to another patient who is actually a 53-year-old man who presented with a progressive proximal weakness of lower limbs followed by upper limbs for 2 years, no cranial nerve involvement, had 3 episodes of worsening of quadriparesis and improved spontaneously in 2 to 4 days. He is a known case of hypothyroidism on treatment with late onset vitiligo and negative family history. CPK was 2,764 and conduction showed a coexisting sensory neuropathy. EMG showed a myopathic pattern in the irritable membrane. McManus showed a 50% reduction in the CMAP amplitude. Lymph node biopsy showed a granulomatous inflammation with AFB stain negative. Muscle biopsy showed features of dense endomysial inflammation, and nerve biopsy showed moderate nerve fiber loss. While in the ward one early morning, he had worsening of weakness with flaccid quadriparesis with provoking insults in the form of fasting, cold weather, and steroids administered for contrast allergy. And potassium was 7.2 and CK increased to 4,294, and weakness improved with correction of potassium. So this is a secondary hyperkalemic periodic paralysis, considered more likely late onset, negative family history, prolonged duration of episodes, and workup for RTA hypercortisolism was negative, started on immunotherapy and did well. So this is a systemic autoimmune disease with a channelopathy. And the factors supporting autoimmune etiology was vitiligo, autoimmune hypothyroidism, a sensory neuropathy, endomysial inflammation on muscle biopsy, and a granulomatous inflammation on lymph node biopsy. Next is actually a 28-year-old male who was actually had an accidental choking while eating and became unresponsive and underwent a bronchoscopy under anesthesia, and post-procedure required ICU care. Developed high-grade fever, hypoxemia, metabolic acidosis, and renal failure, CK values above 6 lakhs. Prolonged hospitalization and low sensorium, and subsequently transferred for further management 1 month later. Assessment revealed flaccid limb weakness, labile blood pressure. Diagnosis was probable malignant hypothermia with recent anesthetic accident. Superimposed critical illness neuropathy, and muscle biopsy showed congenital myopathy with fiber type disproportion. And the course of management, we gave him supportive treatment, avoided inculcating drugs, and gradual improvement of the limb functions, and was weaned him off the ventilator. So this is malignant hypothermia with excessive activation of the ryanodine receptor due to ryanodine receptor 1 mutation of calcium channel and release of calcium from the sarcoplasmic reticulum. Other genetic foci are sodium channels, hyperpyrexia, hypoxia, acidosis, rigidity, weakness, muscle spasms, rhabdomyolysis, triggered by a combination of GA with depolarization, neuromuscular blocking agents, and neuroleptic drugs. So central cord disease, over 25% have a tendency for this. Other myopathies like myotonic disorders and dystrophinopathies can also have this. So Brody's myopathy. The family members rated risk. Again, here we do not have facility for contracture testing, in vitro contracture testing. Next is actually a 32-year-old male who came with diffuse muscle pain, low backache, examination revealed diffuse myokymia, multiple subcutaneous abscess, and was taking indigenous medications for a previous EMG revealed. Unfortunately, the video didn't open here. Couplets and triplets. So there was absent SSR patient that had a lot of hyperhidrosis, had small fiber dysfunction, and needle electrode examination showed abnormal doublets and triplets, showing high intraburst frequency and myokymia and neuromyotonic discharges, and this was thought to be Isaac syndrome, immune mediated due to voltage-gated potassium. Here he had elevated lead levels, 278, and had infection. MRSA was isolated with cutaneous abscesses. He succumbed to MRSA sepsis. We could not do any of the genetic forms of disease are also known. Next is a 12-year-old female who presented with recurrent muscle cramps involving all 4 limbs, back and tongue for 5 years, multiple episodes with worsening with no weakness, primary amenorrhea, short stature, bow legs, muscle spasms, and also had alopecia. So this was like a Satayoshi syndrome. And unfortunately, the EMG was actually showing continuous activity from all the bow legs in her. So she was treated with steroids with significant clinical improvement at 3 months and 6-month follow-up. Next is a 25-year-old man who presents with recurrent episodes of weakness involving all 4 limbs from 10 years of age, fever-induced exacerbation with easy fatigability, poor exercise tolerance, and calf thigh pain after prolonged exercise, recurrent vomiting, weight loss, and GI dysmotility, sensory paresthesias, currently symptomatic for 4 weeks, and similar history in younger sister who had succumbed to disease. Her CK was 4,680, blood lactate was 2, and conduction showed sensory motor neuropathy. Autonomic functions showed GI dysmotility. This was thought to be Mingy, and we couldn't do the thymidine phosphorus gene, and hence we asked the neurochemistry department to get the thymidine phosphorus activity in the leukocytes. And this is basically what the test showed. It was less than 10% of the normative. And this is how the brain looks, showing this is actually in a lady who came before that, white matter changes. and GI and abdominal CT scan of the abdomen showing dilated loops with fluids, showing significant GI. Obviously the muscles are not working well. So basically, this is a Mingy syndrome. This boy was actually treated with hemodialysis followed by ambulatory peritoneal dialysis, and patient made a dramatic improvement. And we are going to look for thymidine and deoxyuridine levels in this patient. Here again, we do not have facility to look for thymidine phosphorylated genetic mutation. Now, this is another lady who presented to us about maybe 14 years ago with a 2-month history of abdominal pain, vomiting, diarrhea, and postural giddiness, antecedent history of mumps 2 weeks before the symptoms, no motor cranial nerves, and normal DTRs. These were the autonomic abnormalities, which are abdominal cold pressure, EI ratio, Valsalva, supine to standing. No exposure to toxins. Workup for porphyria was negative. CSF protein 70. mumps antibody was negative. These are the changes seen in the autonomic workup, and patient was treated with IVIG and fluorocortisone. Dramatic improvement within 10 days. And improved in both autonomic symptoms and testing, and within a month she was normal. Again, this is a post-infectious dysautonomia which we published in Green Journal. And sometimes we see some other patients also there, but we don't have facility to look for autonomic ganglia antibodies other patients. So conclusion, I'd like to conclude saying that you have paroxysmal neurological disorder, symptoms manifest in discrete attacks with intervening normalcy. Triggers for the present and causal triggers causing present and causal effect relationship is not well known due to genetic and etiology could be genetic and autoimmune. Dysfunction is not only at the channel, it could be synapse or a circuit level dysfunction like stiff person syndrome. Now, how do you approach this in a developing world context? Focus on a good neurological examination and history and exam, need for disease-based algorithms, utilize clinical neurophysiological tests, and develop in-house biochemical assays when you can't do the test. This is our department, and thank you very much.
Thank you very much, Dr. Alexander. That was a very comprehensive review. Really do appreciate that. I was wondering, in the U.S., we actually have a paralysis that's related to an insect called the tick, and it's a small parasitic insect, blood-sucking insect. And when you take the tick off, the paralysis resolves typically within 15 minutes, an hour. And I was wondering if there's anything similar here.
This is you're talking about the way you actually pick the tick from below the hair and it's hidden there, and the patient's paralysis improves.
Yep.
Yeah, I haven't seen one. Professor Mishra?
No, I haven't seen.
Are there any other insects in the area that might actually bring on certain types
we have scorpions around, but scorpion bites cause a lot of local reactions. Yep. But snake bites, of course, snake bites are quite common.
This is gastrointestinal forest. Is that a tick causing it? Gastrointestinal forest disease?
Yeah, that's an arbovirus encephalitis.
We have seen some severe hypokalemia and dengue infection. And you treat, and within 2 to 3 hours the patient starts, paralysis improves. And at least we have 2 such cases which we have been reporting the muscle disease in dengue, and we thought it is because of edema and hemorrhage into the muscles.
Okay.
But severe hypokalemia going to 1.8 or 1.9, and you inject in 3 to 4 hours by the evening round, you see the patient's power improve by 4. 2 such cases.
Thank you very much for all of those cases. You obviously feel that you should have some more antibody testing, yes. and I can understand the frustration. But actually there's quite a lot you can do with immunohistochemistry, using blood serum from patients and putting it onto sections of brain tissue, rodent brain, rat or mouse brain tissue. and you can detect quite a lot of antibodies that way. And I would have thought that those were the sort of techniques which could be performed much more frequently than they are now, for not perfect diagnosis, but at least would be helpful.
Thank you.
Any other questions? Thank you very much.
Thank you.
Wonderful overview. Thank you. All right. Well, I think we're about ready to wrap up this afternoon's session. I want to thank all of our wonderful speakers. Give them all a round of applause for an excellent job. I also want to thank my distinguished colleagues who joined me on the panel, and I was honored to be able to work beside them and be with them. And I also want to thank our sponsors for today. So I think, is Christian around? Because I believe we should adjourn for dinner. Although I have to admit, I don't know exactly which way that is. Is it next door? Excellent. So let's adjourn to dinner. Thank you.
If I can just call the faculty to come forward, we would like to honor them in our usual way. And a couple of quick announcements. Please keep your badges for tomorrow. And dinner is served, so please do make your way to dinner once we've done the presentations.